Approach to respiratory infections in immunocompromised patient-based approach. I call upon Dr. Vishnu Rao. Dr. Vishnu Rao is a consultant infectious disease specialist at Apollo Hospitals. He did his MD General Medicine and FNB, DTMH, the UK, and has American Academy of HIV fellowship as well. So he has huge experience over 9 years. And his area of interest is FUO, HIV/AIDS, and transplant-related infections and adult immunization. And he has huge publications to his credit, about 15 publications and 25 presentations at national and international conferences. And he delivered more than 110 lectures at local and national conferences till now. So I request Dr. Vishnu Rao to take over, please.
Thank you, sir. Thank you for that kind introduction. If possible, all the fellows, can you come forward? It will be more interactive. I'd be happy if you all come forward. There's a lot of seats that are empty here. I'm going to present some of the cases. It's more of an interactive session. I'm going to show pulmonary infections in immunocompromised hosts. I think it's around 8 or 9 cases which are interesting in nature. And you can give your differential when I present my case. So without wasting much time, let us, it's not working. Yeah. So essentially, I'm going to cover interesting cases essentially my focus is on immunocompromised hosts, so which includes HIV, solid organ transplant, bone marrow transplants, immunosuppressed patients. These are all the patients I'm going to cover with individual case-based learning. So let me begin my first case. So this is a 35-year-old male who comes with fever for 2 weeks, shortness of breath for 3 weeks, and constitutional symptoms, weight loss. He's hypoxic at presentation, oral candidiasis. On examination, there are bilateral diffuse Krebs. On NIV, found to be HIV positive with a CD4 of 26 and a viral load of 10 lakhs. So this is the X-ray. So somebody who has presented with subacute presentation of progressive shortness of breath with bilateral interstitial infiltrates on the chest X-ray. Now, this is what the CT is showing you in an advanced HIV/AIDS patient who has come with, diffuse bilateral GGO who is hypoxic. So now, what is your differential? Excellent, PCP. So now, what I want to tell you is always consider differential. Okay, always make your list of differentials. Somebody who comes with a bilateral interstitial infiltrates, and in a HIV patient, it is PCP unless otherwise proven. And mind you, at times TB can also atypically present, or you can have a coexisting infection. In an immunocompromised host, you can have surprises. You can have a coexisting diseases. So this is likely PCP, and always rule out coexisting TB in this kind of patients. And for example, if you are in the flu season, somebody can present, it can even be influenza, right? So just because somebody is HIV/AIDS, it doesn't protect them against influenza. Now you have flu season going on. If the same patient comes during an influenza season, irrespective of his HIV status, this can even be influenza pneumonia. But the way it is presented, it is subacute presentation, makes PCP more likely. But obviously, I'm going to keep these other differentials, but down on the cards. Now, so this patient, sputum expert, sputum AFB smear culture negative. Sputum, whatever the expected sample, that is negative, PCP stain, and the gram stain is gram stain culture negative. And in the serum, the BDG is higher. And the PCR also done because this patient has come during the flu season, and the PCR also it's negative for influenza or any other respiratory viruses. So this is probable or probable PCP pneumonia because the consistent presentation and the high serum beta-D glucan. Beta-D glucan is the constituent present in the cell wall of this fungus, and in the appropriate clinical scenario, this has a sensitivity of 85 to 90%. So PCP pneumonia, typically it used to occur in 70 to 80% of the patient with AIDS before ART, presents with fever, shortness of breath, and LDH can be higher, but this is a non-specific marker, and chest X-ray shows bilateral symmetrical interstitial infiltrates. Mind you, when you have a cavitation or lymph nodes or effusion, this makes PCP unlikely. So these are the findings which make somebody has it, this makes PCP unlikely. Now, how do you diagnose? You diagnose with genes and Wright strains, which stains the cyst and trophozoite, and GMS, which stains the cyst wall, and direct immunofluorescence is the test of choice. PCR is other test, but you need to understand in an appropriate setting, PCR has a sensitivity of more than 90%, but if the pretest probability is low, you can have false positives. So now that most of us are sending this fancy PCRs, but always have a pretest probability. If you send PCR for a straight community acquired pneumonia, if you send PCR for PCB, it can be positive. It doesn't mean that patient has PCR, because you can have normal colonizer sitting there. So even colonizers can be picked up. So be very careful when you send these kind of things. In an appropriate clinical scenario, this has very good role, but there are always colonizers possible. Just keep that in mind. And as I told you, the beta-glucan, because most of these patients are hypoxic, they are in NIVs, bronchoscopy is not possible and the sputum sample is not significant enough. So the other indirect way of identifying is by asking a serum beta-glucan, which has the higher levels in the appropriate setting, good sensitivity in this particular setting. So this is PCP pneumonia. So this is the GIMSA stain and this is the GMS stain. This is how PCP looks. And the gold standard is the direct immunofluorescence, basically uses monoclonal antibodies that target PCP. And this is from the bronch from particular patient. And the induced sputum has a sensitivity of only around 50%, BAL has 90 to 95%, and biopsy has obviously 95 to 100%, but these are sick patients. Doing biopsies and all is very difficult. So the other indirect way is by using your serum beta-glucan. Now, the drug of choice is trimethoprim sulfa, and most important is who requires steroids. Somebody, simple words, a PCP pneumonia, he is hypoxic, requires steroid. The simple indications are, PaO2 less than 70 or AA gradient more than 35 mm. So along with the TMPS1, we have a tapering dose of steroids. This is a standard protocol we use for our HIV patients. And we have decent number of patients who develop toxicities because of trimethoprim sulfa, like sulfur drug rash, cytopenias, hyperkalemia, acute increase in creatinine. All this can happen. So if you have any problem with this particular drug, the alternative is clindamycin plus primaquine. The other alternatives like pentamidine and atopicin is not easily available. The simplest is clindamycin and primaquine is what you can use. Now prophylaxis is for someone whose CD4 is less than 200 or WHO stage 3 or 4. Irrespective of their CD4 count. Now, coming to the respiratory infections in a HIV host, the commonest is the recurrent bacterial pneumonias. Next, PCP pneumonia, tuberculosis. These constitutes majority. And mind you, the CMVs, MAC in the lung are not uncommon, but as I told you, in an immunocompromised host, everything is possible. So keep other things are also in mind. Now, when it comes to tuberculosis, TB, when present in a normal host, it typically causes upper lobe cavitary lesions. In an advanced HIV/AIDS, it can present as a community, it can mimic community acquired pneumonia involving mid and lower lobe. And the cavitation is typically absent, and in an advanced HIV host, the extrapulmonary manifestations are more common in up to 50%. So TB in advanced HIV can present as a bacterial pneumonia. You can have mid and lower lobe pneumonias. Keep that in mind. And so this is the higher CD4 count patient where you typically have an upper lobe lesion cavity. But in a lower CD4 count, it can present, it just mimics like a bacterial pneumonia. So please do keep this particular thing in mind. And you can have all other presentations, miliaris or TB effusion. And you can have, one of the other thing is the extrapulmonary nodal tuberculosis. We have good number of HIV patients presents with fever of unknown origin without any clinical localization. Always in this kind of patients, think of mediastinal or abdominal nodal tuberculosis, which are way common in advanced HIV patients. And in fact, the extrapulmonary manifestations are more common in a HIV host. And one of the things I want to tell the pulmonologists here is that whenever somebody has TB in the lungs, when somebody says significant CNS symptoms, they say headache, or please do not ignore thinking that is a simple symptom. You can have a coexisting TB meningitis. The reason it is important is that when somebody has both lung and the brain lesion, when somebody has a TB in the brain, you should give them steroids. Otherwise, once you put on the ATT, they come back with bad immune reconstitution, bad iris syndrome, causing them, lower cranial nerve paralysis or, basal meningitis or tuberculoma seizures. So always keep that in mind. So I have seen significant of patients coming like that. The initial symptoms were being ignored. So just keep that particular thing in mind. Now, TB clinical aspects, you know that AFB smear, and you should send for AFB culture. I'm pretty sure that you're all aware of this. And avoid using fluoroquinolones for treating, community-acquired pneumonias, because good number of TBs atypically present as pneumonias or some with subacute symptoms. And if you give that, because of that, there's a lot of resistance to levofloxacin for our TBs. So avoid using it. And diagnosis, you all know, I think, the AFB smears, AFB culture, gene expert MTB. The one thing what I want to tell is the gene expert second line. Now, somebody who has, in India, one of the main problem is the isoniazid monoresistance. Isoniazid monoresistance is up to the, up to 10 to 15%, and in the previously treated TB patients, it can go up to 25% as the isoniazid resistance. So, and you know that most of the labs are not equipped to do good AFB cultures and susceptibilities. So, when your gene expert is positive, now we are regularly asking gene expert second line to look for isoniazid sensitivity, fluoroquinolone sensitivity. And in fact, as I told you, because of the isoniazid monoresistance is high, this is the other one which will help us to make, adequate decisions. And one important thing is, gene expert ultra, when it is detected low, medium or high, ask for gene expert second line, because not an expert is what is there in the second line. So if it is very low or trace, you may not pick up on this. So just keep that thing in your mind. So you know that the expert comes in as early as 90 minutes. And two other important points. The sensitivity of gene expert is very poor in pleural fluid. The sensitivity is as low as 17%. So if you have a lymphocyte predominant effusion, expert is negative, still it can be TB. And in this era of drug resistant, if you have a suspicion of drug resistant, if you have a pleural effusion, always go for a pleural biopsy. That gives a better answer, because unfortunately the sensitivity compared to clinical gold standard is very, very poor. The duration of treatment, 6 months, and you all know that we're going to continue ethambutol in the continuation phase because of the isoniazid monoresistance in India. And you're going to extend for 9 to 12 months if these are the indications. Now, one point I want to make sure is that, see, now the amount of TB drugs what we are using is high. For example, now the more than 70 kgs, you are getting 5 tablets or 6 tablets of the regular combination pills what we have. Now, we are increasingly seeing two things. Number one is the ocular toxicity with ethambutol. Please, whenever the patient is more than 70 kgs and you try to give 5 or 6 as typically the government gives, always get their ocular examination done. Now we are increasingly seeing ocular toxicities, and we are regularly monitoring everybody at 3 months with the sending to the ophthalmologist to look for the ethambutol induced optic neuritis, especially the color vision. Please keep that in mind. And the second thing I am seeing is the lot of hyperuricemias and gouts, especially when you give pyrazinamide dose more than 1500 and ethambutol dose more than 1200. Please keep these two particular things in mind. We are increasing seeing in this particular. And always you can have atypical presentations. You can have two things. This patient has PCP and biopsy this cryptococoma. This patient has nocardia pneumonia. So you always have you can have two different things in the same patient. Whenever the pattern is different, when you see something else, always think of a coexisting pathology and get your samples done. And whenever somebody is HIV and TB, always look for drug interactions. Rifampicin has drug interaction with PIs and nevirapine. And when we give it dolutegravir, we increase the dose. And whenever the CD4 is less than 50, the ARTB should be started as early, when somebody has TB, ARTB should be started as early as possible within 2 weeks, except the TB meningitis where we wake up to 4 weeks. Now coming to the second case, this is a 50-year-old male who underwent heart transplant for dilated cardiomyopathy. He is CMV recipient status positive on triple immunosuppression on trimethoprim sulfa prophylaxis. He is 6 months post-transplant, presents with fever, cough and 1 week. His CMV viral load is higher, and chest X-ray showed a nodular lesion and hence went for CT. You can see here a nodular lesion. What is this? What do you call this sign? A nodule and a surrounding, ground glassing. It's a halo sign, right? So what is this? Yes, probably aspergillus. Mind you, that is what I'm trying to say. Just because you have halo sign, it doesn't mean that it has to be aspergillosis. Even nocardia can present like this. Mucor can present like this. In a post-transplant, PT-LD can present like this. So always don't look at this, okay, this is aspergillus. Don't start right away on the treatment. Always do a bronch or tissues. You should and must do, because it is not uncommon to have surprises in an immunocompromised host. But so you always frame a differential. So differential in this particular host is nodular lesions in HRCT, fungus, aspergillus, mucor, and whenever you have a halo, think of aspergillus. When you have a reverse halo, most of the times you are seeing mucus, and other things are also possible, but mucor is something you need to think. TB, nocardia, Legionella, PTLD, all these are differential diagnosis, right? So don't jump and think only Aspergillus, others also possible. And when somebody comes after transplant, in the first 1 month, you have typical bacterial pneumonias. In 1 to 6 months, this is the time where you see opportunistic infections. And after 6 months, along with patient goes home and come back with a community-acquired infections like pneumonia, scrub typhus, or it can be a endemic fungus like histo or tuberculosis. Once they go out, along with the immunosuppression-related specific infection, you can even have the regular community-acquired infections. This is the data on what these nodules turn out to be in a SOT patient. Most, if you see the back, infectious constitute 60% and nocardia is common, and you can see other nodular pneumonias are nocardia, TB, Legionella. And if you see fungus, Aspergillus, Cryptococcus. And if you see the non-infectious, you can have malignancies. And whenever you have these fungal infections, usually associated with CMV viremia. See, this patient has CMV viremia. But you need to understand CMV reactivation is associated with the other infections. It is associated with coexisting Aspergillus, PCP or other infections. So always keep that in mind. So the history is that whenever somebody has a nodules, do a CT and ask the history, travel history to look for anything, something unusual, and physical examination. If you have this umbilicated lesion on the skin, this is Cryptococcus can cause in the lung and it can disseminate to the skin, it can go to the brain, cause umbilicated lesions. If you have nocardia can go to the skin and cause cutaneous lesion. If you have cutaneous lesion, these are the other things. And if you have lung and brain syndromes, you think of TB, Aspergillus, nocardia, all this has to be, Cryptococcus, all this has to be kept in mind and all this has to be keep in mind. Now, serum galactomannan. Mind you, serum galactomannan, at least, I would like to tell a practical experience. Serum galactomannan has poor sensitivity in a non-neutropenic host. It's only 20%. In a neutropenic host, the sensitivity is around 80%. And one of the things is that there are lots and lots of false positives. The prior speakers already quoted what all false positives are there. So if there is a lung lesion, why do you ask a serum galactomannan? Go to the lung, ask a BAL galactomannan rather than that. Since when the pretest probability is low, you will land up a lot of false positives. And always when possible, go for BAL and biopsy. Always go for biopsy whenever it's required. So this patient, BAL, gram stain culture negative, expert negative, fungal smear, everything is negative. Galactomannan is 3.5. So the film array, all are negative. So this is probable pulmonary aspergillosis. Now, start treating this patient, look for the clinical improvement and image again later to make sure that you're dealing with the aspergillosis, and all the risk factors are already been told. I don't think I'll continue that. And the treatment is, the drug of choice is voriconazole. The alternative is isavuconazole and posaconazole are also equally effective. One point I want to tell is, compared to voriconazole, isavuconazole has less hepatotoxicity and all azoles cause increasing QT prolongation. Isavuconazole is the one which causes reduction in the QT prolongation. If you have heart issues because of some reason and if the patient is affordable, go with the isavuconazole. Right? Now, TB in the solid organ transplant, one point I want to tell, extrapulmonary and disseminated are it's very common. And rifampicin is contraindicated with tacrolimus. But one point here, if somebody has bad TB, disseminated TB in a transplant patient, we still tend to give rifampicin because rifampicin is the most active drug which is required for saving patient's life. You can give rifampicin after discussing with your transplant surgeon and regularly monitoring TAC levels. We still give it if the patient has disseminated disease. We feel rifampicin is with parallel monitoring of the TAC levels. Keep that in mind. Now coming to the case 3, is a 24-year CKD who's on triple immunosuppression post-transplant, who presents with azotemia. Now he has fever, cough with expectoration, right-sided pleuritic chest pain, lot of blood thin sputum is there. On examination, this is what it is. What is this? There's a big nodular lesion in the lung. What are the differential diagnoses? If you see here, there is some sort of a ground grass here surrounded by a thick rim. So how does it look like? This looks like a reverse halo. So my first suspicion is invasive fungal infection. Is it Aspergillus, or it is mucor, or it is nocardia, or it is PTLD? All these are differential diagnoses. The same thing, whenever you have GGOs surrounding by this, think of mucor. And the same, this patient BAL was done and everything was asked. Nocardia negative, expert AFB smear culture negative. Galactomannan is 3.5. So are you going to, straight away put this patient on Aspergillus treatment, or you want to do anything in this particular case? As I told you, mind you, see, this lesion is way bigger for me to look like aspergillus, and this reverse halo is positive. So I'm somehow not very convinced with the galactomannan. So I went for the biopsy, and the biopsy has showed, broad ribbon-shaped hyphae. Essentially, this is mucor. Then why galactomannan is positive? It can be a co-infection, number one, or it can be a false positive. So whenever you have a reverse halo, or whenever, this patient would have been easily mistaken for aspergillus and you would have treated. Whenever the lesion looks little atypical, little bigger, this patient is on a lot of steroids, always go for tissues because you can have co-infections or you can have a false positive. So otherwise this patient would have been dead if you don't make the diagnosis of mucor. Please keep that in mind. When you think of mucor, whenever you have a reverse halo, you have vessel involvement, you have transbronchial spread. Okay, so all these are the things which will make you suspect mucor, and in doubt always go for tissues. Go for tissue, get a biopsy. You often surprise. Sorry, what is it? I'm sorry. Yeah, so surgical, early diagnosis, proper antifungal and surgical debridement. But when it comes to the pulmonary mucor, it should be decided on individual case basis. The regular dictum of debridement holds true for the sinuses and other areas, but when it comes to the lung, always take a individualized decisions, because the peri-surgical mortality is high, but ideally it is surgery and followed by the medical management, and the treatment already been discussed. Now coming to the next case, this is a 75-year-old female from Vizag who's presented with intermittent fevers, who is a CA breast patient who is on this trastuzumab and pertuzumab, and she has presented with fever. She has a chemo port in place, and there were some peripheral nodular lesions. Biopsy was suggestive of only few inflammatory cells, and TB expert was negative. This is the time they came in with here. So it's an FUO syndrome with pulmonary nodules, predominantly peripheral in location. So since we thought, is it a central line CLAPC with peripheral nodules, or TB, nocardia, all this were taken into consideration, or it is a progression of underlying malignancy. So when we send the blood cultures, the blood cultures has grown gram positive, and when we ask the AFB staining, this is non-tubercular mycobacteria. So whenever you have a peripheral lung lesions, you always think whenever you have a lung lesion, you think of whatever is coming from the lungs. But you can have an infection elsewhere and can see it in the lungs also. See, this patient has a port, and he has a peripheral lesions, and that made us think of and the blood cultures has picked up, and this turned out to be a rapid grower, and this is called as Mycobacterium margaritans, and we have treated accordingly. So whenever you have the lines and all peripheral lesions, not only the lung pathologies, can be from something else, just keep that in mind. Now, this is a 35-year-old doctor who is on Takayasu arthritis, came with, on immunosuppression, has come with right upper lobe cavitary pneumonia, and you thought of all these differential TB, aspergillus, nocardia, etc. And the most important clue here, the AFB is positive in the BAL and the expert is negative. Whenever you have AFB positivity, if it is TB, gene expert should pick it up. If it is not picking up, means it is not TB, and something which looks like TB and not TB is non-tubercular mycobacteria. So this is the clue, and this turned out to be M. abscessus and be treated accordingly. So the clue is that AFB positive, expert negative, think of non-tubercular mycobacteria, and it's not TB. Right? Coming to the case 6, this is a 26-year-old female, AML, neutropenia, who is on 26 days hospitals on antibiotics and antifungal prophylaxis, now presented with shortness of breath, 3 days, and if you see here, there is some centrilobular nodules and there is ground glassing. So bilateral interstitial infiltrates, we thought of viral pneumonia, PCP, all these, and when you tested, it is respiratory syncytial virus. So these are the importance of doing a PCR, because this has treatment in immunocompromised host, and this patient typically treated with ribavirin IVIG with complete improvement. And you know that all these respiratory virus can only picked up on the panel, and in an immunocompromised host, you have certain non-influenza respiratory virus which are treatable, especially neutropenics like RSVs or adenovirus which have treatment. So keep those things in mind. Now I think I'll just finish my slides. And this is the last but one case. This is a post-liver transplant patient who received rituximab prior transplant. Post-surgery, this patient required methylprednisolone and other immunosuppressives. Now, in the hospital, he had a fever, cough, and expectoration and new onset hypotension. And this particular patient has bilateral ground glassings and right-sided effusion. So this is a liver transplant patient, prior received rituximab in the hospital, who developed a bilateral ground glassings. who is on antibiotics, he's on antifungal prophylaxis, everything, not getting better, now ID is involved. Now the same thing, this particular patient, whenever you have a bilateral ground glassing opacities, we think of virus, PCP, everything is negative, and this particular patient next day developed these ulcers in the mouth. So the first thing we thought is it a non-respiratory virus regular? Is this herpes is what we thought based on the painful lesions in his mouth. And when we asked for the HSV1 PCR, it is positive. So you can have viruses which are in the lung, which are not predominantly respiratory viruses. You can get in transplant host and think of something like herpes and CMVs, which can come as pneumonias in this particular host. And the treatment saved this particular patient's life. And after treatment, he got improved. Now, coming to the last case, I think this is one thing you need to remember, which, especially in diabetics, never miss this particular infection. 34-year-old male who comes with fever for 1.5 months, shortness of breath, and osteomyelitis, uncontrolled diabetes, comes with such a bad pneumonia, and the blood culture has grown, blood urine ET has gone, and non-lactose fermenter. What is this? Uncontrolled diabetes, pneumonia, it can mimic TB, it can cause cavities, empyema, it can involve joints, uncontrolled diabetic, it can be mistaken for Pseudomonas. What is it? Melioid. Never forget melioidosis. Melioidosis is very well there in our states. It typically presents, it can present as acute pneumonia or subacute presentation, chronic pneumonia, cavity, empyema. It can cause visceral abscess, bone and joint infection, and it can be mistaken for Pseudomonas in certain areas. So it is very well there, and the commonest risk factor is diabetes. Diabetics frequently gets it, and this is my study which I have presented. There are a lot of cases coming from Andhra and state of Telangana, from the rural area. We have n numbers of melioids, only that it is not regularly identified. So you can see it as a consolidation. If somebody thinks of TB, you can see a big light upper lung. This is a typical, it's a melioid case. You can easily mistaken for TB. This patient was on empiric TB, came back, turned out to be melioid. And it easily goes on your, regular cultures, no specific media is required. Typically goes on your regular culture, good micro lab is required, and always inform your lab. And the treatment, you can form abscesses. You can see how they are forming abscesses on the thigh, and it can form all the abscesses on the head and neck. And these are we call conglomerate lesions in the liver and spleen, very characteristic of melioid. When you have lung lesions and all this, please do think of melioid. It can cause abscesses anywhere in the body. You can see the septic arthritis. This patient has lung and septic arthritis of the knee and the ankle. So please keep this present. Think of melioid in this kind of patients. And the treatment is like TB. You have an induction phase, intensive phase, and an eradication phase. Intensive phase, you give up to ceftazidime or meropenem up to 2 weeks. And for eradication, we give trimethoprim sulfa for almost, up to 3 months we give. So understanding this is very important. I think with this I end my talk. Thank you. Sorry, I took, 7 minutes extra, I guess.